Hello, everyone. My name is Chelsea Libreros-Cortes, along with
Kylie Trebor
and Nicholas Zablocki.
And we are here to present our current and ongoing research with you all. So thank you so much for stopping in. Before we begin, we would like to thank NJSHA for accepting our research and giving us the opportunity to present it to you all. We would also like to thank Kane University, specifically the School of Communication Disorders and Deafness faculty and staff, who have supported our educational careers through these adverse times, and our faculty advisor, Dr. Jessica Schur, for supporting our research. So without further ado, this is how differences in personal style can impact participation in group therapy sessions across delivery models. At the beginning of the academic year, my group members and I were thinking about the different topics that could be investigated, and our faculty advisor brought to our attention the noticeable changes she has seen in returning clients at the Center for Communication Disorders, in other words, our university clinic. She found that many clients had a shift in participation during the transition from in-person sessions to virtual. More specifically, she noticed that individuals who were more extroverted participated less during virtual sessions, and those who were more introverted participated more during virtual sessions. Therefore, we decided to investigate this further and determine the correlation between personal styles and group therapy participation. To get into more detail about our topic, aphasia is a multimodal communication disorder that arises secondary to acquired focal damage to the language processing centers of the brain, creating mild to severe communicative impairments. Group therapy as a form of intervention for individuals with aphasia has been shown to improve social skills and increase language abilities. Typically, group therapy sessions were held in person. However, due to the recent social distancing mandates, there has been a rapid shift to teletherapy as a main service delivery model. It has been observed and studied that individuals may shift their typical performance level when given a different environment. This study hopes to examine how personal styles can impact participation and contribution levels during group therapy sessions across different delivery models. My partner Nicholas will go into further detail about this, but to quickly recap, the participants in the study completed a questionnaire that focused on their personality traits and how they may impact performance during service delivery models for stroke rehabilitation. Additionally, we analyzed in-person and teletherapy group sessions to measure levels of participation. As I mentioned before, data collection for the present study is still ongoing, and we have not been able to access all of the participants' pre-recorded sessions. However, it is hypothesized that individuals who participated less frequently during in-person sessions will have an increase in participation to the session during teletherapy, since specific personality types are considered to have predictive responses to various stimuli and presentation models, which includes in-person meetings and online. This study may have clinical implication as it relates to the clinician's knowledge of their client's personal styles and how it may impact individual participation levels throughout group sessions. What we hope to learn about this study once we're able to gather all of our data is clinicians can learn how different personal styles can impact the success and effectiveness of a teletherapy group therapy sessions. Also, clinicians can learn the benefits of determining their patient's personal styles and preference in order to promote an effective teletherapy session for all group members. And lastly, it can help clinicians who have worked with the same individuals during in-person and telehealth services analyze their patients' behavior and facilitate increased participation during group therapy.
Hello, everyone. I'm Nicholas, and I will be discussing the methods and participants that were included in our study. The participant pool included individuals with aphasia who currently receive speech and language therapy services at the Kane University Center for Communication Disorders and Deafness, otherwise known as the Graduate Student Speech Clinic. These participants have received services both in person and via teletherapy so that their behaviors could be compared and contrasted. While individuals who suffer various forms of focal damage to the brain may experience aphasia, only those who initially presented with a cerebrovascular accident were included in our study. We were granted permission and given an invitation to join virtual group therapy sessions via Zoom, where we then presented our recruitment flyer to all of the clients with a detailed explanation of our study. The clients were advised that by consenting to the study, their previously recorded therapy sessions would be accessed temporarily for professional and research purposes only. The participants of this study were required to complete a 26-item online questionnaire hosted via Qualtrics, which is a HIPAA-compliant survey program that allows us to preserve confidentiality and privacy to all participants enrolled. Participants completed the survey at their own convenience in their desired setting and were provided with our informed consent information prior to completing the survey. Those that did consent were tasked with providing responses regarding their perspectives on their own personal styles before and after their stroke, as well as their perceived overall level of participation across service delivery models. Participant responses to these statements were given on a 5-point Likert scale, ranging from strongly agree to strongly disagree. For example, survey questions included, before my stroke, I consider myself an outgoing person, as well as, after my stroke, I consider myself to be an outgoing person. The participants responded based on how much they agreed or disagreed with each of these statements. Other questions in our survey included, currently, I am an active participant in face-to-face aphasia group therapy, and currently, I participate in telehealth group therapy more than I participated during face-to-face therapy. The information gathered from the participant responses was then used to determine if the participants felt as though they were more introverted or extroverted, depending on the service delivery model. Our study included a total of 7 participants between the ages of 53 and 77 years who have been diagnosed with aphasia secondary to CVA. These individuals were categorized into introvert and extrovert categories based on their survey responses. Participants 1 through 3 were categorized as being introverted. Participant 1 is a male who received a diagnosis of moderate to severe expressive aphasia and is 14 years post-stroke. Participant 2 is a female who received a diagnosis of mild to moderate expressive aphasia and is 3 years post-stroke. Participant 3 is a male who received a diagnosis of moderate expressive and receptive aphasia and is 2 years post-stroke. Participants 4 through 7 were categorized as being extroverted. Participant 4, 6, and 7 are males, and participant 5 is a female. Participant 4 received a diagnosis of moderate receptive and expressive aphasia and is 7 years post-stroke. Participant 5 received a diagnosis of moderate expressive aphasia and is 8 years post-stroke. Participant 6 received a diagnosis of mild expressive receptive aphasia and is 17 years post-stroke. Lastly, participant 7 received a diagnosis of mild to moderate expressive receptive aphasia and is 11 years post-stroke. We were granted access to each of these participants' online files that are stored on a HIPAA-compliant server for the duration of the study. We reviewed previously recorded aphasia group sessions that were conducted both in person and through teletherapy to measure the following areas: the total number of utterances, independent comments, responses to clinicians, responses to peers, and errors, which included word finding, syntax, and articulation errors. This was done in an attempt to determine the overall level of participation from each participant during in-person and teletherapy group sessions. The data obtained from the previously recorded therapy sessions and the survey were then compared to determine if there is a correlation between participant perceptions of their personal style and their level of participation across service delivery models.
Hi everyone, I'm Kylie and I'll be discussing our data and results. Due to COVID-19 and the imposed guidelines, we were unable to obtain completed data for all participants enrolled in in-person group therapy in order to conduct a complete comparison. The charts represented are a breakdown of participants' responses within group sessions held via teletherapy only. The bar graphs titled Total Utterances and Mean Length of Utterance represents the amount of times each participant spoke or participated in the group therapy session, as well as the length in words of each spoken utterance, or how many words spoken per sentence. The dark gray bars represent participants 1 through 3 who identified themselves as introverts, and the light gray bars represent the responses of participants 4 through 7 who identified themselves as extroverts. The average number of utterance for the dark gray introvert group was 59, and the average mean length of utterance was 5.3. For the extrovert light gray participants, the average number of utterance was 65, and the average mean length of utterance was 6.9. Although the results do in fact indicate that on average our extroverted participants spoke more often and used longer utterances, there was no significant difference between the participation levels during virtual group therapy sessions. The pie charts below represent a breakdown of each participant's responses based on type of response. The three categories of response were as follows. Dark gray represents independent responses, light gray represents direct response to peers, and the white represents direct responses to the clinician. For the introvert participants, the average number of independent responses was 43, the direct responses to peers was 11, and the direct responses to the clinician was 25. For the extrovert groups, independent responses were averaged to be 25, direct responses to their peers was 14.25, and direct responses to the clinician was 25.25. The breakdown of these responses indicates that the extrovert group has a greater incidence of direct responses to the clinician and peers, whereas the introvert group's responses tended to be more independent statements. As mentioned previously, our investigation is ongoing and limited data was acquired. However, current data obtained represents the comparison between responses for both in-person therapy and teletherapy for participants 1, 4, and 5. Participant 1 was identified as an introvert, and participants 4 and 5 were identified as extrovert. The dark gray bar in the first bar graph represents the total number of utterances for participant 1, who identifies as an introvert. His total number of utterance was 29, and the average mean length of utterance was 1.6. When breaking down participant 1's responses into the three categories of independent response, direct response to clinician, and direct response to peers, the results are as follows. Independent responses was 4, direct response to clinician was 24, and direct responses to peers was 1. When comparing the total number of responses for participant 1 in both in-person and teletherapy, it shows that participant 1 not only had a greater number of total utterance, but also a longer MLU and more independent responses via teletherapy. Based on the participant's response to the questionnaire, the participant did in fact feel that he participates more in teletherapy than he does in an in-person group. Based on these results, we find that participant 1 is in fact correct and demonstrates great awareness into his own participation levels. As for our extrovert participants 4 and 5, which are represented by the light gray bars, the average total utterance was 111, and the average mean length of utterance was 7.25. When breaking down the responses for these participants, 38 were independent responses, 35 were direct responses to the clinician, and 30 were direct responses to peers. These findings indicate that participants who identified as the extroverts performed relatively the same across both service delivery models. Similar to our introverted participant, these participants responded to the questionnaire stating that they felt their participation was neutral across service delivery models. These findings support their statements and again demonstrate that the participants have awareness into their current levels of participation while in group. Although the research is ongoing and the data is limited, what has been found so far does suggest that individuals who identified as introvert do tend to participate more in group sessions held via teletherapy. As previously mentioned, due to the mandates for distancing guidelines set into place for COVID-19, not all participants were able to be observed within a face-to-face group therapy setting. Continued research and observation in order to provide complete and accurate results based on participation levels is still warranted. So to summarize, with the current data collected from participants 1, 4, and 5, we have found introverted clients participate less frequently in in-person group sessions and are more likely to participate independently in group sessions via teletherapy.
Thank you everyone for taking the time to listen about our ongoing research. Again, my name is Chelsea.
My name is Kylie.
My name is Nicholas.
And again, we would like to thank NJSHA for allowing us to present, and our faculty advisor from King University, Dr. Jessica Shore, for her ongoing support. Everyone enjoy the rest of your week.
There are no financial or non-financial relationships to disclose for this presentation.